Thank you so much for having me here. Before we begin the formal discussion, as some of you, maybe all of you are aware, today is September 11th, 18 years after September 11th that, at least in some parts of the world, changed the world. I would like to ask that we all take about 20 seconds or so for a moment of silence in respect to those emergency responders who gave it all that day. So thank you so much. So my name is Jonathon Feit. I run a company called Lucid Technologies, and as I mentioned, we're going to talk a little bit about emergency response today. And as we discuss the applications of artificial intelligence to fire, EMS, police, military, other interventional responses during crisis moments, I'd like for you to think about this not so much as a discussion of what is happening, but rather a discussion of what could happen. What one of my colleagues might call a vision cast or a future cast as to ways that artificial intelligence, machine learning, and other advanced technologies could transform what is arguably one of the most misunderstood or least understood industries that surround us. And you'll hear me talk a little bit more about the ubiquity of emergency response. But it's still largely a manual industry. And yet I'd like for you to think about what would be the value, what is the urgency in terms of dollars, in terms of time, of information during the most critical moment, when something goes wrong. When, for example, a crisis happens, something blows up, something flies into a building, Ebola walks into a hospital room, an emergency department, and all of a sudden, everything that came before stops and response needs to happen. So think about who and what is involved and where things need to move. Trains need to be rerouted, planes need to be grounded, whole city blocks may need to be cordoned off. That event that took place is the effects are macro in that regard. These are emergency response, emergency interventional steps, and yet they are the sum of all the micro events that took place along the way, the people that were affected, the care that's going to be delayed, the travel plans that need to be re-coordinated. The sum of all of those micro events need to be accommodated and coordinated and basically known and understood. And this is where the public perception of emergency response falls down. When, on a daily basis, someone has a heart attack, a child drowns in a pool, let alone these major events that sort of change not only the regions in which they impact, but far beyond that, there is a public understanding of emergency response that they are fully informed. Or there is this recognition or assumption that they know nothing. That they pick up the patient and they transport them someplace else, and it's basically the most expensive taxi ride you'll ever take, whether by ground or by air. But those of us who are involved in emergency medical services of all of its flavors all over the world understand that, in fact, there's a ton of information that needs to move around. There's a ton of information that needs to be processed. Some of that is pretty fundamental, traffic patterns. Where are you going to take your patient? Distance from the event horizon, this thing that occurred, to wherever you're going to take this patient for the next locus of care, that next step in the process to take care of them, possibly save their life, possibly move people around, rerouting the information about them, such as their health records, and so on and so forth, so that there's knowledge about what goes on. But there's also plenty of information that needs to come back after the fact for continuous quality improvement, quality assurance, making sure that everybody's doing what they're supposed to be doing, and that every link in the chain is fully informed. And yet, that doesn't happen today. In fact, one of the most critical misunderstandings in the public perception of how EMS happens is that information flow is either non-existent or that it's seamless. And in fact, the data, the literature show that on the order of 50% of all patient information, critical information captured in transit, is lost at each node of handoff in a pre-hospital environment. So imagine when we talk about artificial intelligence as big picture stuff, right? How can we solve disease? How can we make markets more efficient? Think about it in the most critical moments that we have, what would it be worth? And what would the value be operationally, clinically, financially, if the information about what happened in those critical moments could be known in real time by the next link in the chain? The top line here, the gray line, shows the process, at least in the Americas today. By the way, the US EMS system is one of the more efficient in the world. There's first aid, there's transport, there's handoff, and then because there's about 50% of information lost, essentially everything that took place in the truck takes place again in the emergency department. Imagine if you didn't have to have that repeat process. What is lost during that redundancy? The US average transport time plus first aid is 27 minutes across the US. In some cases, it's significantly shorter. Places like New York and San Francisco, where hospitals are on every other block. But in some cases, it could be an hour. If you're out in rural America, for example, it could be a substantial amount of time. And if you need more than one vehicle to respond, someone has to wait with the patient until that second transport, that air transport, is scrambled. Imagine if all that information could be front-loaded. And you could utilize artificial intelligence to notify whoever needs to have that information so that they can triage and intake that patient seamlessly while information is being gathered in the vehicle, so it doesn't have to be done again. And you can use things like biometrics to intake that patient, know who they are, their history, and so on and so forth. So let's make it real. Some of you may have heard that there were a couple shootings highlighted here. One in my neck of the woods in Gilroy, California, at a garlic festival a couple weeks ago. Another massive event that gets a ton of attention because it showed the US EMS system just how much work needs to be done in terms of making the information handoff process more efficient. Was the massacre in Las Vegas, where some 250 patients were involved in a scramble across a municipality that's really not designed to handle all of those patients all at once. My focus on the routing and the intelligence behind this process goes back to our founding at Carnegie Mellon University in the city of Pittsburgh, Pennsylvania, where there is a point, there are actually a couple points like this, but there's one in particular. I used to live near it. You can see a map of it on the screen here. That is essentially equidistant from 3 major care facilities in the city of Pittsburgh. So let's assume for a minute that a car accident happens and a patient or patients are burned. Well, that person had a heart attack, which led to a car accident. That's a trauma, which led to a burn. And it turns out that those 3 facilities, one of which has a vascular center designed for cardiac intervention, another has a burn center designed to care for people who have major burn issues across their bodies, and the third has a trauma center for blunt force trauma and so on and so forth. If you're an emergency responder or set of them arriving on scene with one patient or multiple patients, where do you take those patients when you're equidistant from all of them? Why is it that we don't have technology right now helping those emergency responders make that decision? Now let's take that forward to a case like Las Vegas, which again, not theoretical anymore. Where do you take these patients to ensure that each of them goes not only to the closest facility, which at this point may be full, but to the right facility to care for them right now? And more than that, who else needs to be informed of that patient's care? Who is this patient that you're transporting? So many patients that are going to come through the emergency services system have been there before. There's big talk about concepts like health information exchange, big fuzzy concepts that are kind of oversold in many cases. But the reason they're oversold is because one of the hardest parts of the emergency medical system, in fact, EMS, and if you take nothing home with you today, understand the single most unique thing about the EMS industry, the sub-industry of healthcare and health and safety that is emergency medical services, makes it different from every other part of the healthcare system around the world. It's the only part of healthcare that deals with the unknown patient. Walking into a doctor's office, walking into a hospital, from a knowledge transfer perspective, that's easy. I know who you are, I register you. In some cases, we use biometrics when you walk into the door. But in the emergency medical services area, biometrics are essentially unheard of. And yet, if you have a finger, a toe, or an eye, I can find you with positive identification. Even if you're a twin, you have sufficient variability in most cases to be able to identify you in the healthcare system. Why aren't we doing that today? And using that information to not only properly route you for the best care based on your context, but also notify others in your health ecosystem who need to know that you just got transported to the emergency department. Maybe you've been seen several times for congestive heart failure, or COPD, some other chronic condition, or you're addicted to harmful substances. And you've been seen by many people along the way, but when you fell down in the middle of the street, or you were driving and got into a car crash, many of those people have the ability to reconcile that data today. What if we could do that? And what if we could change the EMS processes around the world nearly instantaneously? We just talked about car crashes. So show of hands, who's heard of a system called OnStar? Okay, so OnStar in the United States, a division of General Motors, that essentially provides information after a crash about where that incident took place, whether the airbag deployed. In newer versions of it, there's velocity of impact. There's a lot of other companies that are developing similar telematic systems. And Europe, by the way, is substantially ahead of the United States in terms of requiring that new cars have this type of telematic location-based technology. Would it surprise you, because it surprised me, that there is not a single telematics emergency response system in the world today that provides any information about the people who were impacted during the crash? It's entirely about the vehicle, where the vehicle was, whether the airbag deployed, velocity of impact, not whether the people in it are moving, conscious, breathing. How about how many of them are there? Well, it turns out, let's say you have a minivan traveling with 5 passengers, right? Parents, kids, one of those kids' friends, gets into a car crash, goes into a ditch. Somebody calls 911 driving by, says, send help. In anything other than a mass casualty incident like September 11th, the average, or the maximum number of passengers that can be transported in an ambulance is 2. So for all the math geniuses in this room, what's the minimum number of ambulances you'd need for a 5-passenger crash on the side of the road? 3. But that's not known until the number of passengers in the vehicle is reported. So if someone calls 911 while they're driving by and says, send help, they do. They send a first vehicle. And the need for those second and third vehicle, or an air transport, or a pediatric specialty unit, or any of the other more defined responses that need to show up on scene doesn't even happen until the first one gets there, and then you have to wait again. Why are we still doing that in 2019? Imagine if you could take all the information that's sitting on your wrist, sitting in that car, sitting in the ecosystem around it, knowing everything from temperature changes in the inside of a vehicle, if, say, for example, there's a car fire, to whether that patient is moving, conscious, what's their health history, here's the health information exchange, and convey that into the emergency responders' hands. As it turns out, I spoke with a number of vehicle manufacturers about this capability a number of years ago. You know what Ford told me? The most advanced, by the way, in the industry when it comes to understanding emergency response, ahead of GM, ahead of Tesla, very far ahead of Tesla, ahead of everybody else. They couldn't figure out how to get the vehicle information conveyed into the hands of the emergency responders. That's the area of opportunity, right? If you can utilize artificial intelligence, machine learning, interoperability standards to convey information about who was involved in the crash, what's wrong with them, how many people are there, where they need to go, and what's going to have to happen when they get there, who else needs to be notified, etc. And you can convert that automatically, instantaneously into the standards that exist across the pre-hospital care ecosystem to make it easy to document what happened to that patient. Capture that information instantaneously. Make it fast enough and in useful formats that it can be consumed by the rest of the healthcare system, shared across that healthcare system, and used to follow up with those patients. Leveraging in the United States something called the National EMS Information System, it's the NEMSIS standard, the HL7 behind emergency medical service records, if you will, and then HL7 on the hospital side. Convert that information to a consumable format that they can then take to follow up with that patient after the fact and share with other caregivers in that patient's ecosystem. I had to give a little kudos to my team because we have been called Silicon Valley's emergency medical technology experts. And we have been proud to be disruptors. We're one of the rare companies in health technology out in the Bay Area, at least, that has managed to survive to 10 years. As some in our industry have said, maybe now we have some idea what we're doing. But I hope you take away from this conversation, and I'm happy to answer any and all questions, that there is enormous need to connect the dots in the pre-hospital ecosystem, because unfortunately, the most critical events, where often the least technology is brought to bear, don't necessarily come with a whole lot of planning unless we do so now. Years ago, a colleague and friend of mine answered the following question: what do you do when your systems stop working, your technology systems stop working? And his answer was, we go back to pen and paper. That's bad in 2019. Now, almost everybody in this room knows that the standard of communication for emergency medical handoff, emergency healthcare handoff in general, is fax machines. Today, 2019, fax machines. All the brains in this room need to be brought to bear on the idea that these critical moments when lives truly matter, when whole worlds can change, there are devices in our pockets, on our wrists, and brains in this room that can change that ecosystem that is long overdue. Thank you so much.
Jonathan, some questions? You have 3 minutes.
I don't see so much where you use artificial intelligence to actually to illustrate or to support the process. Because basically it's all about processing information, but what's the place of artificial intelligence in your system?
Great question. So the question was, in fact, I'll just zip back to the front here. So the question was, where does AI apply in the process, essentially? As you mentioned, right now it's a largely manual process. So going back to the major topic here, essentially, what is the right place to take the patient at any given moment based on what their needs are? So imagine the degree to which you could process independent streams of information, ranging from traffic, weather, patient's acuity, patient's history, hospital site capabilities, how many patients are involved, who else is converging on a given set of facilities. And you can do this on a daily basis. For example, Ebola walks into an emergency department, does what we call crash in the emergency department. You can no longer use that emergency department in quarantine. Where do you take those patients? Those patients that are still showing up because word hasn't yet gone out that this emergency department is effectively unusable until it's sterilized or quarantined and so on and decontaminated. Or you have the other extreme. You have the mass casualty event, the 250 patients in Las Vegas, the shooting in Gilroy, the car crash involving 50 cars in Minnesota in the snow. And you need to be able to understand how those disparate streams of information become a decision. And that decision literally can have life and death consequences for the potentially many patients involved. That process is being done manually today. A perfect example is the state of Louisiana. The state of Louisiana in the US, every year, or most years I should say, is affected by hurricanes. In an effort to try to streamline the triage process, the state of Louisiana has a czar that they put in place to manage rotational transport of patients. 1, 2, 3, 4. Essentially, this person, for lack of a better term, plays God when it comes to where do these patients need to go in order to make it equitable, and in order to ensure that the distribution of patients is matched to the capabilities of the hospital in terms of facility, in terms of room for them. It has very little to do with what the needs of the patient are. The opportunity to apply AI to saying, now I'm going to go from simply matching point to point on a location basis to matching point to point based on patient's health history, based on facility capabilities, based on current need of the patient as it evolves in transport, is something that computers are very well equipped to do far faster with so many different streams of information being thrown at them than to be done in the field. I hope that answers the question.
Maybe another question?
Yes.
Hi, yeah, so one of the big problems with response is that it is a reactive situation. And potentially one of the big things with AI is the ability to maybe predict when or where emergencies are going to take place. So looking at traffic situations, looking at mass events going on, and trying to use those to maybe implement that in the system so you can predict where ambulances were needed, what hospitals would need to be on standby. Do you see that being a thing in the future?
Absolutely. So predictive analytics and predictive modeling of essentially where to station resources and where they may need to be responded to, not only based on populations, but time of day, for example. I'll give you a more acute example, or a specific acute example of where that's being applied now, and it's really in its infancy, is drug overdose. So, for example, the opportunity to use predictive modeling on not only populations and regions, but even individual patients based on their health history, as to understanding, for example, if an individual or a population is paid in cash, for example, on Friday afternoon. Friday night, Saturday morning, where are these patients going to be found because they've gone out drinking, obtaining substances, et cetera, et cetera. There are communities that have been substantially impacted on that, particularly in the United States, particularly in certain regions of the United States, that are looking to prevent overdose and prevent those addictions from happening, and they're looking to use that information, which they haven't typically had access to in real time. And going back to the previous question of you, if this information being thrown at you, and the way most of the United States operates, it takes that data and processes it sometimes over as much as 6 months to understand where those hotspots are. If you could use that information in real time and process multiple streams of data, then you could see on a much narrower window where those patients are likely to be, how you can prevent them from getting to that point in the first place, and again, not only be their emergency medical responder, which I think is your point, as opposed to helping them to obtain better health over time. Thank you so very much.
Thank you so much.